Alright guys, this video is going to look at healthcare in Australia. This is our first video for the critical question, what role do healthcare facilities and services play in achieving better health for all Australians? Your syllabus has your learn about here for healthcare in Australia. It says that you need to learn about the range of and types of health facilities and services. You need to know the responsibility for health facilities and services across Australia. You need to think about the equity of access to these health facilities and services. You have to know about healthcare expenditure versus expenditure on early intervention and prevention. You need to know about the impact of emerging new treatments and technologies on healthcare. Particularly there, you need to think about the cost and also the access that people have, as well as the benefits of early detection and stuff that come with those technologies. And then finally, we have to have a look at health insurance, looking at the differences between Medicare and private. Our Learn 2 asks you to evaluate healthcare in Australia by investigating issues of access and adequacy in relation to social justice principles. You need to explore questions such as how equitable is access and support for all sections of the community, and how much responsibility should the community assume for individual health problems. And then the final Learn 2 there is for you to describe the advantages and disadvantages of Medicare and private health insurance, particularly thinking about costs, choices, and the benefits of ancillary care. So let's have a look at the range and types of health facilities and services in Australia. So in Australia, we have institutions, which are our hospitals, both private and public, and also our nursing homes. We then have non-institutional things like going to your GP. There's research groups, there's pharmaceutical services. They are not institutional. So institutional, essentially, you're looking at, well, within healthcare system, you're looking at things that have beds mostly. Then we can also classify things in terms of how they're funded. So we have lots of publicly funded services. So that can include emergency care, pharmaceuticals through our pharmaceutical benefits scheme. It might be surgery, rehab, it might be midwifery care, some diagnostic services, might be visiting GPs and specialists. Some mental health care is also publicly funded, respite care, and a lot of community health centres are also publicly funded. But that doesn't consider things like our physiotherapists, our occupational therapists, dentists and stuff, because they actually fall outside of the publicly funded model, and that falls into the privately funded stuff. And they're also a large aspect of our healthcare system. Possibly one of the hardest things when it comes to this dot point is having a look at who is responsible for what, because quite often this shifts and changes within Australia's politics. So in Australia, when it comes to our publicly funded and the responsibilities of our government, essentially our government is responsible for a lot of the recurrent expenditures. So this is things like health goods and services, a lot of administration stuff and research. So our government will fund a lot of that and are responsible for that. So often that means that actually you work for the government when you're doing research, or you're working for the government in admin. And so you think of the Australian Institute of Health and Welfare, that's all funded and run by the government. Those people work for the government. We also have a lot of primary healthcare that's done underneath our government in terms of their role and responsibility. So that can include things like hospitals, it can include things like dental services and other health practitioners. State and territory governments, so now shifting from our national government to the lower level, essentially really they're just going to be responsible for the running of our public hospitals and services that are related to that, probably including our community health centres as well. And then our private providers, so they run our private hospitals, but then pretty much any primary health service where you're paying for it, that's privately run. GPs are privately funded. A lot of medications that you're getting from your chemists when you go shopping, and also a lot of recurrent expenditure and unreferred medical services tend to be within the private system. So if you need to get a walker, or you need some crutches or anything like that, those types of things, normally if you're paying for them, private. When it comes to funding, this is separate and different to the responsibilities. So our government is responsible for certain things like the running of the Australian Institute of Health and Welfare, the Australian Bureau of Statistics, so those types of things our government is responsible for, and doing that, producing reports and stuff. Whereas funding is actually slightly different. This is where the government is responsible for funding it, but not necessarily for running it. That doesn't mean they aren't responsible for running. Some things that they fund, they do run as well. So the Commonwealth government at the national level, they are responsible for funding both the public and the private hospitals. They don't completely fund private hospitals, they do provide a fair bit of money for them. They also fund a lot of the primary health services. So this includes the medications that you buy, going to your GP or going to community health services. And much of the recurrent expenditure in research and medications is also going to fall under our Commonwealth government banner. When we step down then to the state and territory governments, state and territory governments are responsible for funding really most of the funding that goes into public hospitals and also some private. They are responsible for funding community and public health in the primary health services. And they're also responsible for a lot of administrative and research type tasks within their state. Then we have some private funding. So private funding is essentially things like private hospitals are going to mostly be funded privately and be owned privately. A lot of dental practices and medical practitioners are pretty much all health practitioners. So your osteos, your physios, your chiros, your naturopaths, your acupuncturists, your masseuse, your exercise physiologists, they're all going to fall into that privately funded type stuff. And also a whole bunch of other goods and services are going to also fall into some privately funded things. Now you need to also think about the equity of access to these health facilities and services. So essentially within Australia, because our population distribution is so wide and sparse, it makes equity of access to health facilities and services really difficult. And so most Australians who live in metropolitan or city areas, they have lots and lots of hospitals and lots of health services readily available to them. But that's not the case for people who live out in rural and remote areas. So people out in rural and remote areas have less access to health services and less access to health facilities because it's not monetarily viable for our government to do that. So for example, they have fewer hospitals in our rural and remote areas. We have fewer private practicing hospitals especially. We have fewer specialists out there. And so our government has tried to work out ways to really address those issues. And so they've come up with things like the rural flying doctors who will fly people from wherever they are in rural and remote areas to a regional hospital, or they might fly them all the way into a metropolitan area depending on what the person needs. We have e-health records and we have telehealth technology where essentially we're using technology to do video conferencing with specialists in rural areas. ATSI also have less access, particularly to things like dentists, general practitioners and hospitals. The reported barriers from our ATSI population are that they have long waiting times, that the cost of the facilities and services is out of their reach, that the services are unavailable in their area, and also that the services are culturally inappropriate for them. Obviously, people of lower socioeconomic status also are going to struggle to have the same kind of access to health facilities and services as those of higher socioeconomic status. And Australia has brought in, in 1984, they brought in Medicare to really help address that. And then the pharmaceutical benefit scheme that's gone along with that has really helped to reduce that barrier, but it's still not covering things like your physios, your doctors. Though you will get part rebates for it, it's not covering the full cost. When you think about health facilities and services, the health expenditure, the amount of money our government is spending is actually ginormous. And so you need to think about healthcare expenditure versus early intervention and prevention. And I'm going to tell you that the amount we're spending on early intervention and prevention is minimal. Okay, so we're spending 1.7% of our health expenditure on early intervention and prevention. So that's $2.23 billion a year. When I put that into perspective for you, Australia spends over $140 billion on healthcare, and that is continually going up. Some of the major things that money is being spent on in terms of intervention and prevention are things like our vaccines, that gets a lot of the money, and also the scans that are done, particularly around cancer. Those types of things are taking up a lot of our healthcare expenditure that is looking at intervention and early intervention. It's looking at prevention and early intervention. Now, you also need to think about the impact of emerging new treatments and emerging technologies on our healthcare system, on its access, on its costs, on its funding and stuff. And essentially, if you're looking at technology and new treatments, it's always going to be expensive. And if those expenses are not covered by our government through Medicare, then that means that that new treatment, that new technology is only available to those people who have a lot of money, who can afford it. So some of those really big things that are going to cause a lot of costs, that are new treatments and new technologies, some of them are covered by our government and some of them are not. Let's have a look at a few. So the HPV vaccine is covered by our government and is helping to, or aims to, reduce the HPV infection, and then they have linked that with cervical cancer. We've come up with less invasive surgery methods such as keyhole surgery, which is used for knees and kidneys and for hernias and stuff, and that's reducing the time that people are off work and increasing recovery rates. We've improved the mechanics of replacement knees and hips and heart valves. We have new drugs for various diseases, including HIV and a lot of cancer treatments. A lot of new chemotherapies are coming out. We've improved artificial organs, such as our artificial kidneys. So these technologies and these treatments, they improve the detection, they improve the treatment, they improve the outcomes of the person's health who is receiving them, but they also come with increased cost. And so that increased cost really brings into question all those social justice principles, the equity of access, and all those types of things that need to be considered when we're looking at our health system in Australia and the way that it functions and works. So that then brings us to our health insurance, and we're going to look at Medicare and private. So basically in Australia, Medicare came out in 1984, and it covers all of your hospital stays in public hospitals. It's going to cover a large portion of GPs, and in some cases it'll still cover the full portion as long as your GP decides to bulk bill that. It'll also cover some aspects of ancillary care, provided you've got references from your GPs or something that say that you need it for your health. Then we switch over to private health insurance. So our private health insurance has the benefits of you don't have to pay the Medicare levy surcharge, you don't have to pay the lifelong health cover loading, and so we have the government providing these incentives to really make the higher income earners more likely to take out private health insurance. The aim of that, as far as the government is concerned, is to really decrease the government's expenditure and increase personal contributions to healthcare. The benefit is mostly going to be for your higher socioeconomic status people, but also provide funds to be more available for the people of lower socioeconomic status through our Medicare system. Now, obviously, one of the key things about using health insurance companies is that they are businesses, and they would not get into the business unless they were making money from it. And so let me assure you that private health insurance is making plenty of money and is very big business. So private health insurance providers, they provide patients with choice. So you get to choose things like your specialists, you can choose your GP, you can choose your care provider, all within a hospital system if you go to a private hospital, or even in a public hospital if you want to pay as a private patient within a public hospital. It'll cover some of the costs of ancillary care, such as dentists and physios, etc. And it'll also financially support some preventative actions. If you get a letter from your GP, for example, that says you're obese or overweight and you need to go to a gym in order to help improve your health and reduce your likelihood of getting other lifestyle diseases, some private health insurance companies will actually fund or partially fund your gym membership in order to make sure that it's available to you.